Hello everyone, today we'll be looking at motivational interviewing. This is a chapter of a book, chapter 3 of the book Enhancing Motivation for Change in Substance Abuse Treatment. Okay, substance abuse can include anything that's addictive and harmful. For example, smoking, or alcohol, or any recreational drugs. Okay. Motivational interviewing is a technique in which you become a helper in the change process and express acceptance of your client. It is a way to interact with substance using clients, not merely as an adjunct to other therapy approaches, and a style of counseling that can help resolve the ambivalence that prevents clients from realizing personal goals. Motivational interviewing builds on Carl Rogers' optimistic and humanistic theories about people's capabilities for exercising free choice and changing through a process of self-actualization. The therapeutic relationship for both Rogerian and motivational interviewers is a democratic partnership. Your role in motivational interviewing is directive, with a goal of eliciting self-motivational statements and behavioral change from the client, in addition to creating client discrepancy to enhance motivation for positive change. Essentially, motivational interviewing activates the capability for beneficial change that everyone possesses. Although some people can continue change on their own, others require more formal treatment and support over the long journey of recovery. Even for clients with low readiness, motivational interviewing serves as a vital prelude to later therapeutic work. Motivational interviewing is a counseling style based on the following assumptions. Ambivalence about substance use and change is normal and constitutes an important motivational obstacle in recovery. So ambivalence is your friend. Ambivalence means they are unsure, they want to quit but they don't want to quit. So they are at that stage where they are unsure. Ambivalence can be resolved by working with your client's intrinsic motivations and values. The keyword here being intrinsic. So these motivations and values have to come from the client themselves, and it is not an external factor. The alliance between you and your client is a collaborative partnership to which you bring important expertise. An empathic, supportive, yet directive counseling style provides conditions under which change can occur. Direct argument and aggressive confrontation may tend to increase client defensiveness and reduce the likelihood of behavioral change. This chapter briefly discusses ambivalence and its role in client motivation. 5 basic principles of motivational interviewing are then presented to address ambivalence and to facilitate the change process. Opening strategies to use with clients in the early stages of treatments are offered as well. The chapter concludes with a summary of 1997 review by Noonan and Moyers that studied the effectiveness of motivational interviewing. Ambivalence. Individuals with substance abuse disorders are usually aware of the dangers of their substance using behavior but continue to use the substances anyway. They may want to stop using substances, but at the same time, they do not want to. They enter treatment programs but claim their problems are not all that serious. These disparate feelings can be characterized as ambivalence, and they are natural, regardless of the client's state of readiness. It is important to understand and accept your client's ambivalence because ambivalence is often the central problem, and lack of motivation can be a manifestation of this ambivalence. If you interpret ambivalence as a denial or resistance, friction between you and your clients tend to occur. So we are doing motivational interviewing. When you sense ambivalence, so they are wanting to quit but not wanting to quit at the same time, you should look at it as a normal phase, not something that like denial or resistance. The motivational interviewing style facilitates exploration of stage-specific motivational conflicts that can potentially hinder further progress. However, each dilemma also offers an opportunity to use the motivational style to help your client explore and resolve opposing attitudes. Examples of how these conflicts might be expressed at different stages of change are provided in Figure 3.1. So these are the different stages of change. There's 5 stages. First stage is pre-contemplation. Second stage is contemplation. Third stage, preparation. Fourth stage, action. And fifth stage, maintenance. Preparation, sometimes people word it as determination as well. So if you see determination, it's the same as preparation, third stage. In pre-complication, let's open this. In pre-contemplation, client conflict. I don't see how my cocaine use warrants concern, but I hope that by agreeing to talk about it, my wife will feel reassured. I don't want to see how my cocaine use warrants concern, but I hope that by agreeing to talk about it, my wife will feel reassured. Contemplation. I can picture how quitting heroin would improve my self-esteem, but I can't imagine never shooting up again. So in pre-contemplation, they don't want to change yet. This part here is an external factor. My wife will feel assured. So it's the wife who is being worried. And he just wants to make his wife reassured. In this case, there's more ambivalence in the sense that they know and want to quit, know about the harm of heroin, know about the improvement after quitting heroin, and wants to quit, but it can't imagine not taking the substance again. Preparation. I'm feeling good about setting a quit date, but I'm wondering if I have the courage to follow through. I guess they're displaying ambivalence in all these sentences. Action. Staying clean for the past 3 weeks really makes me feel good, but part of me wants to celebrate by getting loaded. It's quite confusing. They want to quit, but then they want to get back again. So in all stages of change, there's actually an element of ambivalence to it. In maintenance, these recent months of abstinence have made me feel that I'm progressing towards recovery, but I'm still wondering whether abstinence is really necessary. Ambivalence again. Let's look at the 5 principles of motivational interviewing. In their book, Motivational Interviewing, Preparing People to Change Addictive Behavior, Miller and Rolnick wrote, motivational interviewing has been practical in focus. The strategies of motivational interviewing are more persuasive than coercive, more supportive than argumentative. The motivational interviewer must proceed with a strong sense of purpose, clear strategies and skills for pursuing that purpose, and a sense of timing to intervene in particular ways at incisive moments. The clinician practices motivational interviewing with 5 general principles in mind. Express empathy through reflective listening. So listen and reflect and express empathy. Develop discrepancy between clients' goals or values and their current behavior. Discrepancy. So, you talk to them and then you know their goals, but their current behavior, they're not quitting yet. So, I think you make it obvious to them that the difference between their goals and their current behavior. Avoid argument and direct confrontation. That's for sure. If you argue, um, it will just make your rapport with the patient go down the drain, and then the patient wouldn't listen to a word that you say. So don't argue with the patient. Adjust to client resistance. Adjust to client resistance rather than opposing it directly. Okay, that's how you avoid arguments. Support self-efficacy and optimism. So when they're looking at the bright side, or when they have their own values which are motivating them to quit, support all these things. Support their optimism, support their self-efficacy. Okay, first, express empathy. Empathy is a specifiable and learnable skill for understanding another's meaning through the use of reflective listening. It requires sharp attention to each new client statement and the continual generation of hypotheses as to the underlying meaning. An empathic style communicates respect for and acceptance of clients and their feelings, encourages a non-judgmental collaborative relationship, allows you to be a supportive and knowledgeable consultant, sincerely compliments rather than denigrates. Let's see what that means. Denigrate, criticize unfairly. Okay. Sincerely compliments rather than denigrates. So you compliment them rather than criticize them unfairly. Listens rather than tells. Gently persuades with the understanding that the decision to change is the client's. Yeah. So you support self-efficacy here. Provides support throughout the recovery process. Support them. Empathic motivational interviewing establishes a safe and open environment that is conducive to examining issues and eliciting personal reasons and methods for change. So when you're listening, it's a more conducive environment for the patient to tell you their issues and personal reasons for change. When they tell you the personal reasons for change, you can use that, like reiterate it back to them that this change is through themselves, is from their own, not an external factor. So you can empower them with their own personal reasons. A fundamental component of motivational interviewing is understanding each client's unique perspective, feelings, and values. Your attitude should be one of acceptance, but not necessarily approval or agreement, recognizing that ambivalence about change is to be expected. Motivational interviewing is most successful when a trusting relationship is established between you and your client. Expressing empathy. Acceptance facilitates change. Skillful reflective listening is fundamental to expressing empathy. Ambivalence is normal. Although empathy is the foundation of a motivational counseling style, it should not be confused with the meaning of empathy as identification with the client or the sharing of common past experiences. In fact, a recent personal history of the same problem area may compromise a counselor's ability to provide the critical conditions of change. The key component to expressing empathy is reflective listening. So the way they want you to look at empathy in motivational interviewing is reflective listening. Listen to the patient. Whereas the definition of empathy is putting yourself in the person's shoes. So you shouldn't confuse yourself with this as will compromise your ability to provide the critical conditions of change. Okay. Native Americans. Okay, if you are not listening reflectively, but are instead imposing direction and judgment, you are creating barriers that impair the therapeutic relationship. The client will most likely react by stopping, diverting, or changing directions. 12 examples of such non-empathic responses have been identified. So these are 12 examples of non-empathic responses. So examples of responses towards non-empathic responses. Ordering or directing. Direction is given with a voice of authority. The speaker may be in a position of power, parent, employer, or the words may simply be phrased as spoken in an authoritarian manner. So these are all the do nots. Ordering or directing. Do not order or direct them. Warning or threatening. These messages are similar to ordering, but they carry an overt or covert threat of impending negative consequences if the advice or direction is not followed. The threat may be one the clinician will carry out, or simply a prediction of a negative outcome if the client doesn't comply. For example, if you don't listen to me, you'll be sorry. Or if you don't stop smoking now, you just get another recurrent stroke sooner or later. So these are do nots in motivational interviewing. Giving advice, making suggestions, or providing solutions prematurely or when unsolicited. not ask for. So if they don't ask for advice, don't give advice. Or if they are not ready, it's prematurely giving advice. The message recommends of a course of action based on the clinician's knowledge and personal experience. These recommendations often begin with phrases such as, "What I would do is." So don't give advice when they're not ready or when they didn't ask for it. Persuading with logic, arguing or lecturing. The underlying assumption of these messages is that the client has not reasoned through the problem adequately and needs help to do so. Okay, so don't persuade them using logic, arguing or lecturing. If you are doing this, you're assuming that they have not reasoned through, but in the matter of fact, most people who are involved in substance abuse or substance misuse already thought it through and already know the harms of these things. Moralizing, preaching, or telling clients their duty. These statements contain such words as should or ought to convey moral instructions. Basically, you shouldn't tell them what to do, right? Ordering, directing, preaching, persuading or lecturing, giving advice. You shouldn't tell them what to do. Judging, criticizing, disagreeing, or blaming. Judging, criticizing, disagreeing, or blaming. These messages imply that something is wrong with the client or with what the client has said. Even simple disagreement may be interpreted as critical. Agreeing, approving, or praising. Surprisingly, praise or approval also can be an obstacle in the message sanctions or implies agreement with whatever the client has said. So you don't agree also. Unsolicited approval can interrupt the communication process and can imply an uneven relationship between the speaker and the listener. So if they don't ask for approval and you approve, you agree with what they said, it can interrupt the communication process and imply an uneven relationship. So the speaker, which is the patient or client, and the listener, who is the doctor or motivational interviewer, there'll be an uneven relationship. So if you're agreeing with what they say, they feel that they are very good and they are very smart and that they are at a higher level than you, so they might not listen to you. Right. Reflective listening does not require agreement, so don't agree with them as well. Shaming, ridiculing, labeling, or name calling is definitely a no-no. These messages express overt disapproval and intent to correct a specific behavior or attitude. Interpreting or analyzing. Clinicians are frequently and easily tempted to impose their own interpretations on the client's statement and to find some hidden analytical meaning. Interpretive statements might imply that the clinician knows what the client's real problem is. Okay. Don't try and interpret what they say. I mean, if you want to interpret, just interpret it in your head. Don't tell them your interpretation. Reassuring, sympathizing, or consoling. Oh, you shouldn't say. Sympathize and empathize are two different things. Okay, reassuring. Don't reassure, don't console, don't sympathize. Clinicians often want to make the client feel better by offering consolation. Such reassurance can interrupt the flow of communication and interfere with careful listening. Oh, okay. The reason is that you interrupt with the flow of communication. So the client might be telling you about there's something bad that happened to them, maybe a death of a family member, uh, and then you might be tempted to sympathize with them, but don't do it, as it might interrupt with the flow. So later on, he might have told you about their reason for quitting, their intrinsic motivations for quitting, but you already interfered with the flow of communication, so they didn't tell you instead. So it's better to just listen carefully. Questioning or probing. Clinicians often mistake questioning for good listening. Although the clinician may ask questions to learn more about the client, the underlying message is that the clinician might find the right answer to all the client's problems if enough questions are asked. In fact, intensive questioning can interfere with the spontaneous flow of communication and divert it in directions of interest to the clinician rather than the client. Okay, so you can ask questions, but what's happening in my screen? Something's wrong with my screen. Okay. Where were we? Okay, you can ask questions, but not too much. Like not every single sentence you ask questions. There'll be like you're directing them towards what you're interested in. So don't ask too many questions. Withdrawing, distracting, humoring, or changing the subject. Alright. Although humor may represent an attempt to take the client's mind off emotional subjects or threatening problems, it can also be a distraction that diverts communication and implies that the client's statements are unimportant. So don't do these kind of things. Don't withdraw, distract, or humor, or change the subject. Ethnic and cultural differences must be considered when expressing empathy because they influence how both you and your client interpret verbal and nonverbal communications. This only applies in the US, so I'm not gonna go through it yet. Not in this video. Develop discrepancy. Motivation for change is enhanced when clients perceive discrepancies between their current situation and their hopes for the future. So this is the second principle of motivational interviewing. First is express empathy, and this is through reflective listening, not putting yourself in their own shoes, but more of reflective listening. Number two is develop discrepancy between the client's goals and values and their current behavior. So we are looking at that right now. Developing discrepancy. Motivation for change is enhanced when clients perceive discrepancies between their current situation and their hopes for the future. Your task is to help focus your client's attention on how current behavior differs from ideal or desired behavior. Discrepancy is initially highlighted by raising your client's awareness of the negative personal, familial, or community consequences of a problem behavior and helping them confront the substance use that contribute to the consequences. Although helping a client perceive discrepancy can be difficult, carefully chosen and strategic reflecting can underscore incongruities. Oops. What's going on? Incongruity means the state of being incongruous, incompatibility. So I should search incongruous. Not in harmony or keeping with the surroundings or other aspects of something. Incongruent. Okay, the incongruent just means the same as discrepancy. I'll use another word. Separate the behavior from the person and help your client explore how important personal goals, for example, good health, marital happiness, financial success, how personal goals are being undermined by current substance use patterns. This requires you to listen carefully to your client's statements about values and connections to community, family, and church. If the client shows concern about the effects of personal behavior, highlight this concern to heighten the client's perception and acknowledgement of discrepancy. So listen and highlight their concerns back to them. Once a client begins to understand how the consequences or potential consequences of current behavior conflict with significant personal values, amplify and focus on this discordance until the client can articulate consistent concern and commitment to change. Oh, right. So you just reiterate. Listen to them carefully and reiterate back to them, and amplify and focus on the difference between their personal values, their goals, and their current behavior. So, one useful tactic for helping a client perceive discrepancy is sometimes called the Columbo approach. This approach is particularly useful with a client who prefers to be in control. Essentially, the clinician expresses understanding and continuously seeks clarification of the client's problems but appears unable to perceive any solution. A stance of uncertainty or confusion can motivate the client to take control of the situation by offering a solution to the clinician. Ooh. Okay, so you listen to them. This approach, this Columbo approach, works for those patients who like to be in control. So as a clinician, you listen to them and then you show that you're confused or you don't know what to say, and then the patient might step in and offer a solution to the clinician himself, which is a good thing because when they offer the solution themselves, they're more likely to follow it because it's intrinsic, not extrinsic, not from the clinician. It's not like the doctor told me to do it. It's my own idea and I'm gonna commit to it. Tools other than talking can be used to reveal discrepancy. For example, show a video and then discuss it with the client, allowing the client to make the connection to his own situation. Juxtaposing different media messages or images that are meaningful to a client can also be effective. This strategy may be particularly effective for adolescents because it provides stimulation for discussion and reaction. You can help your client perceive discrepancy on a number of different levels, from physical to spiritual and in different domains, from attitudinal to behavioral. To do this, it is useful to understand not only what an individual values, but also what the community values. For example, substance use might conflict with the client's personal identity and values. It might conflict with the values of the larger community. It might conflict with spiritual or religious beliefs, or it might conflict with the values of the client's family members. Thus, discrepancy can be made clear by contrasting substance-using behavior with the importance the clients ascribe to their relationship with family, religious groups, and the community. Developing discrepancy. Developing this awareness of consequences helps clients examine their behavior. A discrepancy between present behavior and important goals motivates change. The client should present the arguments for change. Because the doctor or the motivational interviewer should not advise the client what to do if not asked, if the client didn't ask for it. The client's cultural background can affect perceptions of discrepancy. For example, African Americans may regard addiction as chemical slavery, which may conflict with their ethnic pride and desire to overcome a collective history of oppression. Moreover, African Americans may be more strongly influenced than white Americans by the expressed values of a larger religious or spiritual community. In a recent focus group study with adolescents, African American youths were much more likely than other youths to view cigarette smoking as conflicting with their ethnic pride. They pointed to this conflict as an important reason not to smoke. Interesting. The Colombo approach. Sometimes I use what I refer to as the Colombo approach to develop discrepancy with clients. In the old Colombo TV series, Peter Falk played a detective who had a sense of what had really occurred, but used a somewhat bumbling, unassuming Socratic style of querying his prime suspect, strategically posing questions and making reflections to piece together a picture of what really happened. As the pieces began to fall into place, the object of Colombo's investigation would often reveal the real story. Avoid argument. You may occasionally be tempted to argue with a client who is unsure about changing or unwilling to change, especially if the client is hostile, defiant, or provocative. However, trying to convince a client that a problem exists or that change is needed could precipitate even more resistance. If you try to prove a point, the client predictably takes the opposite side. Arguments with the client can rapidly degenerate into a power struggle and do not enhance motivation for beneficial change. When it is the client, not you, who voices arguments for change, progress can be made. The goal is to walk with the clients, accompany the clients through treatment, not drag them along. Directing client's treatment. A common area of argument is the client's unwillingness to accept a label such as alcoholic or drug abuser. Miller and Rolnick stated that there is no particular reason why the therapist should badger clients to accept a label or exert great persuasive effort in this direction. Accusing clients of being in denial or resistant or addicted is more likely to increase their resistance than to instill motivation for change. We advocate starting with clients wherever they are and altering their self-perceptions, not by arguing about labels, but through substantially more effective means. Although this conflicts with some clinicians believe that clients must be persuaded to self-label, the approach advocated in the Big Book of Alcoholics Anonymous is that labels are not to be imposed. Rather, it is a personal decision of each individual. Avoiding arguments. Reprinted with permission, arguments are counterproductive. Defending breeds defensiveness. Resistance is a signal to change strategies. Labeling is unnecessary. So resistance is signals to change strategies means if the patient or the client is resisting, it's a signal for you to change strategies. Yeah, it means you're doing something not right, and you for that individual, and you should try something else. Where are we right now in the 5? Express empathy, develop discrepancy, done. Avoid argument, adjust to the client's resistance. Now we're at number 4, roll with resistance, adjust to the client's resistance rather than opposing it directly. Roll with resistance. Resistance is a legitimate concern for the clinician because it is predictive of poor treatment outcomes and lack of involvement in the therapeutic process. Resistance is a legitimate concern for the clinician because it is predictive of poor treatment outcomes and lack of involvement in the therapeutic process. One view of resistance is that the client is behaving defiantly. Another, perhaps more constructive viewpoint is that the resistance is a signal that the client views the situation differently. This requires you to understand your client's perspective and proceed from there. Resistance is a signal to you to change direction or listen more carefully. Resistance actually offers you an opportunity to respond in a new, perhaps surprising way, and to take advantage of the situation without being confrontational. Adjusting to resistance is similar to avoiding argument in that it offers another chance to express empathy by remaining non-judgmental and respectful, encouraging the client to talk and stay involved. Try to avoid evoking resistance whenever possible and divert or deflect the energy the client is investing in resistance towards positive change. How do you recognize resistance? 4 common behaviors which indicate that the client is resisting treatment. Okay, so let's look at this. So this is how you recognize that the client is resisting. Number 1, the client is arguing with you. The client contests the accuracy, expertise, or integrity of the clinician. The client challenging. The client directly challenges the accuracy of what the clinician has said. Discounting. The client questions the clinician's personal authority and expertise. Hostility. The client expresses direct hostility towards the clinician. Second sign of resistance, interrupting. The client breaks in and interrupts the clinician in a defensive manner. Talking over. The client speaks while the clinician is still talking without waiting for an appropriate pause or silence. Cutting off. The client breaks in with words. Obviously intended to cut the clinician off. Now wait a minute, I've heard about that enough. Denying. The client expresses unwillingness to recognize problems, cooperate, accept responsibility, or take advice. Blaming. The client blames other people for problems. Disagreeing. The client disagrees with a suggestion that the clinician has made, offering no constructive alternative. This includes the familiar yes, but, which explains what is wrong with suggestions that are made. Sorry, just let me drink some water. Excusing. The client makes excuses for his behavior. Claiming impunity. The client claims that she is not in any danger from drinking. Minimizing. The client suggests that the clinician is exaggerating risks or dangers, and that it really isn't so bad. Pessimism. The client makes statements about himself or others that are pessimistic, defeatist, or negative in tone. Reluctance. The client expresses reservations and reluctance about information or advice given. Unwillingness to change, the client expresses a lack of desire or an unwillingness to change. Ignoring, the client shows evidence of ignoring or not following the clinician. Inattention, the client's response indicates that she has not been paying attention to the clinician. Non-answer, in answering a clinician's query, the client gives a response that is not an answer to the question. No response, the client gives no audible, verbal, or clear non-verbal reply to the clinician's query. Sidetracking, the client changes the direction of the conversation that the clinician has been pursuing. So these are signs of resistance, and when you see any of these signs, it's time for you to change strategies. That's what is meant by roll with resistance. So we look at figure 3.2. How do you recognize resistance? Figure 3.2 depicts 4 common behaviors that indicate that a client is resisting treatment. So the 4 common behaviors are arguing, interrupting, denying, and ignoring. How do you avoid arguing and instead adapt to resistance? Miller and colleagues have identified and provided examples of at least 7 ways to react appropriately to client resistance. First one of 7 ways. First of 7 ways is simple reflection. So how do you react to resistance? Simple reflection. The simplest approach to responding to resistance is with non-resistance by repeating the client's statement in a neutral form. This acknowledges and validates what the client has said and can elicit an opposite response. Client. For example, client says, "I don't plan to quit drinking anytime soon." So this is part of denying. Here, unwillingness to change. The client expresses lack of desire and unwillingness to change. So the client says, "I don't plan to quit drinking anytime soon." Clinician, "You don't think that abstinence would work for you right now?" You don't think that abstinence would work for you right now. Amplified reflection. Another strategy is to reflect the client's statements in an exaggerated form, to state it in more extreme way, but without sarcasm. This can move the client towards positive change rather than resistance. For example, the client says, "I don't know why my wife is worried about this. I don't drink any more than any of my friends." The clinician says, "So your wife is worrying needlessly." Double-sided reflection. A third strategy entails acknowledging what the client has said, but then also stating contrary things she has said in the past. This requires the use of information that the client has offered previously, although perhaps not in the same session. For example, the client said, "I know you want me to give up drinking completely, but I'm not going to do that." Clinician, "You can see that there are some real problems here, but you're not willing to think about quitting altogether." Shifting focus. You can diffuse resistance by they're talking of resistance like it's a bomb. So diffuse a bomb, diffuse resistance by helping the client shift focus away from the obstacles and barriers. This method offers an opportunity to affirm your client's personal choice regarding the conduct of his own life. For example, the client says, "I can't stop smoking reefer when all my friends are doing it." Reefer is something you smoke, I guess. "You're way ahead of me. We're still exploring your concerns about whether you can get into college. We're not ready yet to decide how marijuana fits into your goals." So you redirect them. Agreement with a twist. A subtle strategy is to agree with the client, but before this you say not to agree. Strange. But with a slight twist of change of direction that propels the discussion forward. Okay. So in handling resistance, you can agree with the patient and then you do a slight twist. Let's see how. The client says, "Why are you and my wife so stuck on my drinking? What about all her problems? You'd drink too if your family were nagging you all the time." Clinician: "You've got a good point there, and that's important. There is a bigger picture here, and maybe I haven't been paying enough attention to that. It's not as simple as a person's drinking. I agree with you that we shouldn't be trying to place blame here. Drinking problems like these do involve the whole family." Reframing. A good strategy to use when a client denies personal problems is reframing, offering a new and positive interpretation of negative information provided by the client. Reframing acknowledges the validity of the client's raw observations but offers a new meaning for them. For example, the client says, "My husband is always nagging me about my drinking, always calling me an alcoholic. It really bugs me." Clinician: "It sounds like he really cares about you and is concerned, although he expresses it in a way that makes you angry. Maybe we can help him learn how to tell you he loves you and is worried about you in a more positive and more acceptable way." So you reframe it back to them in a more positive tone. In another example, the concept of relative tolerance to alcohol provides a good opportunity for reframing with problem drinkers. Many heavy drinkers believe they are not alcoholics because they can hold their liquor. When you explain that tolerance is a risk factor and a warning signal, not a source of pride, you can change your client's perspective about the meaning of feeling no effects. Thus, reframing is not only educational but sheds new light to the client's experience of alcohol. It's a very good point. So most people think that, oh, I can drink a lot because I don't get drunk. I can control my liquor. But you can reframe back to them that this tolerance to alcohol is actually a warning signal. It's a risk factor, not a source of pride. Rolling with resistance. In summary, momentum can be used to good advantage. Perceptions can be shifted. New perspectives are invited but not imposed. The client is a valuable resource in finding solutions to problems. Siding with the negative. One more strategy for adapting to clients' resistance is to side with the negative, to take up the negative voice in the discussion. This is not reverse psychology, nor does it involve the ethical quandaries of prescribing more of the symptom as in a therapeutic paradox. Typically, siding with the negative is stating that the client has already said, "Oh, what's wrong with my screen?" Typically, siding with the negative is stating what the client has already said while arguing against change, perhaps as an amplified reflection. If your client is ambivalent, you're taking the negative side of the argument evokes a yes but from the client, who then expresses the other positive side. Be cautious, however, in using this too early in treatment or with depressed clients. For example, the client says, "Well, I know some people think I drink too much and I may be damaging my liver, but I still don't believe I'm an alcoholic or in need of treatment." The clinician replies, "We've spent considerable time now going over your positive feelings and concerns about your drinking, but you still don't think you are ready or want to change your drinking patterns. Maybe changing will be too difficult for you, especially if you really want to stay the same. Anyway, I'm not sure you believe you could change even if you wanted to. Oh, taking the negative side, huh? Why is it not reverse psychology? It sounds like reverse psychology to me. Okay, but you can only do this in the later stages, not in early stages or not in patients with depression. Support self-efficacy. Oh, my screen. My screen. Moving on to support self-efficacy, let's see where we are in the 5 main principles of motivational interviewing. Number 1, express empathy through reflective listening. Done. Develop discrepancy between the client's goals or values and the current behavior. Done. Avoid argument and direct confrontation. Done. Adjust to the client's resistance rather than opposing it directly. Done. And lastly, point number 5, support self-efficacy and optimism. We're almost there. Support self-efficacy. Many clients do not have a well-developed sense of self-efficacy and find it difficult to believe that they can begin or maintain behavioral change. Improving self-efficacy requires eliciting and supporting hope, optimism, and the feasibility of accomplishing change. This requires you to recognize the client's strengths and bring these to the forefront whenever possible. Unless a client believes change is possible, the perceived discrepancy between the desire for change and feelings of hopelessness about accomplishing change is likely to result in rationalizations or denial in order to reduce discomfort. Okay, sorry. Let me just read again. Many clients do not have a well-developed sense of self-efficacy and find it difficult to believe that they can begin or maintain behavioral change. Improving self-efficacy requires eliciting and supporting hope, optimism, and the feasibility of accomplishing change. This requires you to recognize the client's strengths and bring these to the forefront whenever possible. Okay, so recognize what are the client's strengths and and highlight it back to them. Unless a client believes change is possible, the perceived discrepancy between the desire for change and feelings of hopelessness about accomplishing change is likely to result in rationalizations or denial in order to reduce discomfort. I see. So, giving them confidence in their own strengths works in harmony with highlighting discrepancy between their desire of change and their goals, because if they are not confident in themselves, they'll just rationalize the discrepancy as in a denial. Because self-efficacy is a critical component of behavioral change, it is crucial that you, as a clinician, also believe in your client's capacity to reach their goals. Discussing treatment or change options that might still be attractive to clients is usually helpful. Even though they may have dropped out of other treatment programs or returned to substance use after a period of being substance-free, it is also helpful to talk about how persons in similar situations have successfully changed their behavior. Other clients can serve as role models and offer encouragement. Nonetheless, clients must ultimately come to believe that change is their responsibility and that long-term success begins with a single step forward. The AA motto, one day at a time, may help clients focus and embark on the immediate and small changes that they believe are feasible. Education can increase clients' sense of self-efficacy. Credible, understandable, and accurate information helps clients understand how substance use progress to abuse or dependency, making the biology of addiction and the medical effects of substance use relevant to the client's experience may alleviate shame and guilt and instill hope that recovery can be achieved by using appropriate methods and tools. A process that initially feels overwhelming and hopeless can be broken down into achievable small steps towards recovery. In summary, self-efficacy, belief in the possibility of change, is an important motivator. The client is responsible for choosing and carrying out personal change. There is hope in the range of alternative approaches available. Okay. Now moving on to 5 opening strategies for early sessions. So these are early stages where you are seeing them for the first few times. Clinicians who adopt motivational interviewing as a preferred style have found that 5 strategies discussed below are particularly useful in the early stages of treatment. They are based on 5 principles described in the previous section: express empathy, develop discrepancy, avoid argument, adjust to rather than oppose client resistance, and support self-efficacy. Helping clients address their natural ambivalence is a good starting point. Helping clients address their natural ambivalence is a good starting point. These opening strategies ensure your support for your client and help the client explore ambivalence in a safe setting. The first 4 strategies, which are derived from client-centered counseling, help clients explore their ambivalence and reasons for change. The 5th strategy is specific to motivational interviewing and integrates and guides the other 4. In early treatment sessions, determine your client's readiness to change or state of change. Is it in pre-contemplation, contemplation, determination, or what was that again? Pre-contemplation, contemplation, preparation, action, and maintenance. So one of these stages, which stage is your client in? Be careful to avoid focusing prematurely on a particular stage of change or assuming the client is at a particular state because of the setting where you meet. As already noted, using strategies inappropriate for a particular change stage or forming an inaccurate perception regarding the client's wants or needs could be harmful. Therefore, try not to identify the goals of counseling until you have sufficiently explored the client's readiness. Ask open-ended questions. Asking open-ended questions helps you understand your client's point of view and elicits their feelings about a given topic or situation. Open-ended questions facilitate the dialogue. They cannot be answered with a single word or phrase and do not require any particular response. They are a means to solicit additional information in a neutral way. Open-ended questions encourage the client to do most of the talking, help you avoid making premature judgments, and keep communication moving forward. Listen reflectively. Reflective listening, a fundamental component of motivational interviewing, is a challenging skill in which you demonstrate that you have accurately heard and understood a client's communication by restating its meaning. That is, you hazard a guess about what the client intended to convey and express this in a responsive statement, not a question. Reflective listening is a way of checking rather than assuming that you know what is meant. Reflective listening strengthens the empathic relationship between the clinician and the client and encourages further exploration of problems and feelings. This form of communication is particularly appropriate for Early stages of counseling, reflective listening helps the client by providing a synthesis of content and process. It reduces the likelihood of resistance, encourages the clients to keep talking, communicates respect, cements the therapeutic alliance, clarifies exactly what the client means, and reinforces motivation. This process has a tremendous amount of flexibility, and you can use reflective listening to reinforce your client's positive ideas. The following dialogue gives some examples of clinicians' responses that illustrate effective reflective listening. Essentially, true reflective listening requires continuous alert tracking of the client's verbal and non-verbal responses and their possible meanings, formulation of reflections at the appropriate level of complexity, and ongoing adjustments of hypotheses. For example, clinician says, "What else concerns you about your drinking?" Client says, "Well, I'm not sure I'm concerned about it, but I do wonder sometimes if I'm drinking too much." Too much for you, for my own good, I guess. I mean, it's not like it's really serious, but sometimes when I wake up in the morning, I feel really awful and I can't think straight most of the morning. A clinician says it messes up your thinking, your concentration. Client says, "Yes, and sometimes I have trouble remembering things." Clinician says, "And you wonder if that might be because you're drinking too much?" Client says, "Well, I know it is sometimes." Clinician says, "You're pretty sure about that, but maybe there's more." Client says, "Yeah, even when I'm not drinking, sometimes I mix things up, and I wonder about that." Clinician says, "Wonder if alcohol's picking my brain, I guess." Clinician says, "You think that can happen to people, maybe to you?" Client says, "Well, can't it? I've heard that alcohol kills brain cells." Clinician says, I can see why that would worry you." Client says, "But I don't think I'm an alcoholic or anything." Clinician says, "You don't think you're that bad off, but you do wonder if maybe you're overdoing it and damaging yourself in the process." Client says, "Yeah, kind of scary thought. What else worries you?" Summarize. The most clinicians find it useful to periodically summarize what has occurred in a counseling session. Summarizing consists of distilling the essence of what a client has expressed and communicating it back. Summaries reinforce what has been said, show that you have been listening carefully, and prepare the client to move on. A summary that links the client's positive and negative feelings about substance can facilitate an understanding of initial ambivalence and promote the perception of discrepancy. Summarizing is also a good way to begin and end each counseling session, and to provide a natural bridge when the client is transitioning between stages of change. Summarizing also serves strategic purposes. In presenting a summary, you can select what information should be included and what can be minimized or left out. Correction of a summary by the client should be invited, and this often leads to further comments and discussion. Summarizing helps clients consider their own responses and contemplate their own experience. It also gives you and your client an opportunity to notice what might have been overlooked as well as incorrectly stated. Affirm. When it's done sincerely, affirming your clients supports and promotes self-efficacy. More broadly, your affirmation acknowledges differences the client has experienced, the difficulties the client has experienced. By affirming, you are saying, "I hear, I understand," and validating the client's experiences and feelings. Affirming helps clients feel confident about marshalling their inner resources to take action and change behavior. Emphasizing their past experiences that demonstrate strength, success, or power can prevent discouragement. For some clients, such as many African Americans, affirmation has a spiritual context. Affirming their inner guiding spirit and their faith may help resolve their ambivalence. Several examples of affirming statements follow. I appreciate how hard it must have been for you to decide to come here. You took a big step. I think it's great that you want to do something about this problem. That must have been very difficult for you. You're certainly a resourceful person to have been able to live with the problem this long and not fall apart. That's a good suggestion. It must be difficult for you to accept a day-to-day life so full of stress, I must say. If I were in your position, I would also find that difficult. Elicit self-motivational statements. Engaging the client in the process of change is the fundamental task of motivational interviewing. Rather than identifying the problem and promoting ways to solve it, your task is to help the client recognize how life might be better and choose ways to make it so. Remember that your role is to entice the client to voice personal concerns and intentions, not to convince them that a transformation is necessary. Successful motivational interviewing requires that clients, not the clinician, ultimately argue for a change and persuade themselves that they want and can improve. One signal that the client's ambivalence and resistance are diminishing is the self-motivational statement. 4 types of motivational statements can be identified. Cognitive recognition of the problem. For example, I guess this is more serious than I thought. Effective expression of concern about the perceived problem. I'm really worried about what's happening to me. A direct or implicit intention to change behavior. I've got to do something about this. Optimism about one's ability to change. I know that if I try, I can really do it. Figure 3.4 illustrates how you can differentiate a self-motivated statement from a counter-motivational assertion. You can reinforce your client's self-motivational statements by reflecting them, nodding, and making approving facial expressions and affirming statements. Encourage clients to continue exploring the possibility of change. This can be done by asking for an elaboration, explicit examples, or more details about remaining concerns. Questioning beginning with "what else?" are effective ways to invite further amplification. Sometimes asking clients to identify the extremes of the problem, for example, what are you most concerned about, helps to enhance their motivation. Another effective approach is to ask clients to envision what they would like for their future. From there, clients may be able to begin establishing specific goals. So we've learned about motivational interviewing, and let's see what they say about the effectiveness of this kind of interviewing. A recent review of 11 clinical trials of motivational interviewing concluded that this is a useful clinical intervention and appears to be an effective, efficient, and adaptive therapeutic style worthy of further development, application, and research. Motivational interviewing is a counseling approach that more closely reflects the principles of motivational. Where did my screen go? Okay. Motivational interviewing is a counseling approach that more closely reflects the principles of motivational enhancement than the variety of brief interventions reviewed in Chapter 2, and it also links the basic precepts to the stages of change model. Of the 11 studies reviewed, 9 found motivational interviewing more effective than no treatment, standard care, extended treatment, or being on a waiting list before receiving the intervention. 2 of the 11 studies did not support the effectiveness of motivational interviewing, although the reviewers suggested that the spirit of this approach may not have been followed because the providers delivered advice in an authoritarian manner and may not have been adequately trained. Moreover, one study had a high dropout rate. 2 studies supported the efficacy of motivational interviewing in a standalone intervention for self-identified concerned drinkers who were provided feedback about their drinking patterns but received no additional clinical attention. 3 trials confirmed the usefulness of motivational interviewing as an enhancement to traditional treatment. 5 supported the effectiveness of motivational interviewing in reducing substance using patterns of patients appearing in medical settings for other health-related conditions, and 1 trial compared a brief motivational intervention favorably with a more extensive alternative treatment for marijuana users. Motivational interviewing and managed care. In addition to its effectiveness, motivational interviewing is beneficial in that it can easily be applied in a managed care setting where issues of cost containment are of great concern. Motivational interviewing approaches are particularly well suited to managed care in the following ways. Low cost motivational interviewing was designed from the outset to be brief intervention and is normally delivered in 2 to 4 outpatient sessions. Efficacy. There is strong evidence that motivational interviewing triggers change in high-risk lifestyle behaviors. Effectiveness. Large effects from brief motivational counseling have held up across a wide variety of real-life clinical settings. Mobilizing clients' resources. Motivational interviewing focuses on mobilizing the client's own resources for change. Compatibility with healthcare delivery. Motivational interviewing does not assume a long-term client-therapist relationship. Even a single session has been found to invoke behavioral change, and motivational interviewing can be delivered within the context of larger healthcare delivery systems. Emphasizing client motivation. Client motivation is a strong predictor of change, and this approach puts primary emphasis on first building client motivation for change. Thus, even if clients do not stay for a long course of treatment, as is often the case with substance abuse, they have been given something that is likely to help them within the first few sessions. Enhancing adherence. Motivational interviewing is also a sensible prelude to other healthcare interventions because it has been shown to increase adherence, which in turn improves treatment outcomes. That's the end of this article. I'd like to summarize this whole piece of chapter, In summary, there are 5 principles of motivational interviewing. The first one is express empathy through reflective listening. Secondly, develop discrepancy between clients' goals or values and their current behavior. Thirdly, avoid argument and direct confrontation. Fourthly, adjust to clients' resistance rather than opposing it directly. Fifth, support self-efficacy and optimism. And there are suggestions on how you can apply these 5 principles, and these are: number 1, ask open-ended questions. Number 2, listen reflectively. Number 3, summarize. Number 4, affirm. Number 5, elicit self-motivational statements. And motivational interviewing has been shown by studies, clinical trials, many clinical trials, to be effective. And these are the benefits. It's low cost, it's effective, it's efficient, and it gives the client something to take home even in the first few sessions, because you are empowering them with their own resources. So it's their own ideas, their own suggestions on how they're going to change. I think that's all I have for you. Thank you.